Okay, now we're going to talk about coronary artery bypass graft surgery, otherwise known as a CABG. There is an animated video that is embedded in here. Again, you might have to stop to watch it. But what this tells you what you're going to do. What are you going to assess? You're going to assess for pain, vital signs, peripheral circulation, I&O, lung sounds, note any shivering, any fever, all part of vital signs, chest tube drainage, EKG, electrolytes, ABGs, and incision for infection. There are so many things that happen when someone has a CABG. First of all, they are in the ICU for at least 24 hours. Then they come to a step down unit. So this is all more informational than anything for you. You might be involved in the teaching. We just cracked their sternum open. So they can't push, they can't pull. We'll give them a pillow. Usually heart centers have heart-shaped pillows that are real firm and you teach the patient to hold the pillow and cough and deep breathe. We want these patients lifting with their legs, not with their arms, because again, we don't want that sternum splitting open. No lifting. Can't raise their elbows higher than their shoulders. To wash their hair, we're going to teach them to bend their elbows and lower their head. So when you think of bypass surgery, I know you're thinking about all of the medical stuff that happens and all of those drips and all that stuff. But remember, that's not what an LPN does. So when you go to RN school, you're going to learn a whole bunch of different stuff about bypass surgery. But mostly, if you are in a situation to care for anyone with any of these disease processes, your job is going to provide comfort and to look for anything that could be going wrong. You are not required to know all of these procedures, but in general, you want to know, what do you do pre-op? You get a vital sign before any meds are given. You hold meds, they're NPO. All of those kind of things for a surgical procedure are always the same. So do not overthink it. I know you're going through these videos thinking, she's not putting a bunch of information on here. And there's a reason that I'm not, because you don't need to know it. And the videos of the surgical procedures are simply for your own interest. If you want to watch rn.com, that's fine. But remember, that's RN. And it's great information. And you'll be doing some of it, but not all of it. So please don't overstudy or overthink these procedures. They're more informational than anything else. I think transmyocardial laser revascularization is one of the coolest things I've ever seen. And basically, it's almost archaic. This is done when nothing else has worked. These patients might have 20 stents, 30 stents. They're still not getting vascularization to parts of the heart. They might have had bypass surgery already, and nothing seems to be working. So what they do is they go in and they create these little channels that bleed into the cardiac muscle. It's really amazing, and it works. Sometimes it works for years and years. So I think it's just very, very interesting. Patients that have had this, they've tried everything else, and they're still not getting blood supply to certain parts of the heart. So they just start poking holes in it. And then it pokes right through into the ventricle. And so they get nice, fresh blood right out into these places. To me, very, very interesting. Here is another interesting one for you. It's a ventricular aneurysm repair. This is the heart, and this is an aneurysm. Very, very serious complication of a myocardial infarction. And basically what happens is a weak or dying section of the wall of one of the ventricles, it's under so much pressure that it expands and bulges out like a balloon. So this is the left ascending artery right here. And it has bulged way out of the left ventricle because it's just not getting the supply it needs. And so they go in there and hopefully they can fix it. Afterwards, usually scar tissue forms. They can sometimes fix these via cath. Sometimes it requires surgery, certainly emergent. Symptoms include shortness of breath, chest pain, arrhythmias. If left untreated, the patient's heart will fail. They'll have blood clots. It could burst. Lots of things can happen. So it needs to be treated emergently. And again, let's talk about things that an LPN won't be involved in unless you're just there to be a organ donor cheerleader. Cardiac transplants. Donors have to be less than 40 years old. They cannot have cancer, severe hypertension, or diabetes, and they must weigh within 20 pounds of the recipient. The recipient's age, of course, younger is better. They cannot have any pulmonary hypertension, and there are just many, many, many rules on what's required for cardiac transplant. So again, interesting thing, saves lives. Another interesting fun fact, they're getting now where they will replace the heart and lungs quite often together because they're finding that that gives better outcomes. This patient goes through everything that somebody that had bypass will go through, as far as the chest being open and all that. And then on top of that, they're on rejection medications for the rest of their lives. That makes them very susceptible to infections, cancers, and other diseases, because anti-rejection meds are telling them not to reject things. So the last thing they're going to do, so the anti-rejection medicines also make them not reject bacterias, and cancer cells can proliferate. Here are indications for cardiac transplant, and I'm going to let you read those on your own. Here is a therapeutic measures, diuretics. We have to be very careful that they don't have fluid volume overload. And you'll see this is an ICU patient. They're on telemetry, they're ventilated, they have a temporary pacemaker, chest tubes. Get on YouTube and key in images of cardiac transplant surgery, and you'll not be able to find the patient within all of this stuff. All right, the last thing I'm going to do, and I'm going to go through this very quickly because we're covering rhythms in SIM, sorry. And we are also then gone over most of what you need to know. So these are cardiac, the views of an echocardiogram, P wave, QRS, T wave. We've gone over all of this. Cardiac dysrhythmias, you know, when you read the strip, you can figure out, is it AFib? Is it VTach, VFib? And this gives you kind of the timing for all those as far as normal seconds for the PR, QRS, QT. Again, we're doing that in SIM, but this is just a kind of a review. And there's the 6 steps. Here's the boxes. This is all repeated. And I wanted to make sure that I cover things that are important here. This is normal sinus rhythm, so this is a healthy heart. The other thing you want to know are some brief interventions for easy things. Normal sinus rhythm, no interventions needed. Here's some dysrhythmias. Sinus arrhythmia, usually benign. Occasionally, if it's symptomatic, we do something, but sinus arrhythmia rarely needs anything. Sinus tachycardia, again, it depends on the cause of it. If they're tachycardic because of overuse of drugs, running, if it's something that we can relieve very quickly, we don't need to do any treatment. But if we do have to do treatment, it will be beta blockers, so metoprolol, or diltiazem, which is cardizem. That can bring the heart rate down very, very quickly. Sinus brady, again, it depends on how low it is and whether it's symptomatic. Somebody with a heart rate in the 50s does not need any care. If their normal heart rate drops to the 20s, they probably need a pacemaker. AFib, aflutter, we're going to treat both of these the same. They look different, but they're what's going on in the heart is just a little bit different, but treatment's the same, and the treatment is usually anticoagulants. So this patient will be on warfarin, and then usually maybe DIG, something that makes their heart contract much more efficiently. And then as they age, if the AFib is continual, they might go into heart failure, and then we have to make sure they don't go into fluid volume overload, so they'll be on some diuretics if symptomatic. Atrial fib can be caused by a lot of different things. It's kind of like the heart gets irritated, and so different things can irritate it. Pericarditis is one of the causes. So pericarditis is an inflammation of the pericardial sac around the heart. We've talked about that before. And pericarditis left untreated, one of the preludes to it is AFib. So that's a warning. There's something going on here. Left untreated, that can lead to cardiac tamponade, which basically means there's so much fluid that the heart does not have the ability to move. That is the easy definition of cardiac tamponade. Treatment for AFib, again, all of these options, anticoagulation is the most important. And then depending on the severity of the AFib, how long they've had it, and what works will be the other choice. And every patient's just a little bit different. But again, we're going to use something that gives them overall health and makes the most of the contraction of the heart. Aflutter is pretty much the same as AFib. If they have AFib or aflutter that's very, very rapid and they're symptomatic, we might have to cardiovert them. So cardioversion is a treatment that it's the same kind of defibrillation you use in a code. It's just not as much electricity. So if somebody has symptomatic AFib, aflutter, and it's very rapid, they will cardiovert them. And again, you would not be involved with the patient that much as an LPN, because the nurse's job is to help sedate the patient and then recuperate them, but that patient would be considered unstable. So a post-synchronized cardioversion patient would not be given to an LPN. So most of this, again, is for your information, but you do want to know how we're going to treat these rhythms. All right, here's some ventricle dysrhythmias, and that means that the ventricles are pumping fine. The question is, are they pumping before the atrium? So a PVC is a premature ventricular contraction. So if you look on this rhythm strip here, you have a P wave here. See a P wave here? Well, what you don't see in this weird looking QRS complex, see how wide it is? There's a P wave in there. So that's what makes it wide, because it's like sharing the space. So in bigeminy, you have a normal beat and a PVC, and a normal beat and a PVC. Bigeminy, that means every other one. Trigeminy is the same, only different. And in a trigeminal rhythm, again, if you could see in here, there is a P in there, and that's what makes this QRS so wide. And that's why you need to know how to measure QRS. Now, I'm not testing you on measurements, and the boards aren't, but they might test you on rhythms, and they probably won't even test you on a PVC at all, but they might test you on VTAC or VFib. These are both shockable rhythms. These are both code rhythms that, you know, there's no way out. We have to shock this patient. Again, bigeminy, every other beat is a PVC. Trigeminy, every other beat every third beat. So bi means 2, tri means 3. So 1, 2, 1,